Hi, I'm Jack Cush, Executive Editor for Room Now. I'm coming to you today from the ACR, and today I want to talk about the recently released ACR guidelines, which appeared online yesterday. These are an aggressive attempt to codify the things that we do in rheumatology, which are sometimes difficult to, in fact, explain. This particular guideline is devoted to rheumatoid arthritis, specifically early rheumatoid arthritis, established RA, and patients who have specific comorbidities. It is based on a number of different treatment scenarios. It is based on evidence gleaned from the literature. Hence, a large number of randomized controlled trials had to be reviewed for these results. Not surprisingly, many of the guideline recommendations that we do have actually have a low evidence for their recommendation. Nonetheless, there are several things that we should say. One, the expected things that we're seeing in these guidelines are that early RA should be treated aggressively with methotrexate and or DMARD that is most acceptable to the patient and the physician. Monotherapy is preferred early in disease. Those who have more aggressive forms of early RA may require more therapy. There is a recommendation for limited steroid use in early RA, up to 3 months at the lowest possible dose. Chronic, long-term steroid use is recommended for those with established disease and moderate to high disease activity not responding to conventional therapies. Across the board, there is a recommendation for a treat-to-target strategy. Not surprising, but then again, this is not frequently employed by U.S. rheumatologists. When it comes to established disease, this is where it got really difficult. Many different scenarios were examined. For those who fail a DMARD who fail a DMARD, no particular order was given to the next choice of therapy, whether it be a TNF inhibitor, a non-TNF biologic, a combination of DMARDs, which is surprising and goes against what is commonly practiced in the U.S. But then again, this is a low evidence for this recommendation. If you have failed one TNF inhibitor, the next step is to go to a non-TNF inhibitor biologic, not to keep switching TNF inhibitors. If you are not in remission, if you are in low disease activity, it is not recommended that you stop therapy or wean therapy because the flares are probably going to ensue. However, for patients who do in fact assume a new state of remission, the recommendations do say that you can wean therapy, not saying specifically which one, but you should not try to discontinue therapy. That would be a big mistake. And lastly, they got quite contentious when it came to comorbidity issues. Some of the things that are on the list, I'm to read from these. CHF, anything is allowed to treat a patient with RA and CHF, but a TNF inhibitor. This is surprising because if you actually look at the data on this, RA patients with going on TNF inhibitors do not have more cardiac events, do not have worsening of their heart failure. So they're recommending basically everything else that's never been studied. And all of that recommendation is based on trials of TNF inhibitors in heart failure patients where it did not work out. The mechanism by which TNF inhibitors do cause worsening of heart failure in heart failure patients is really never been quite explained. Hepatitis B patients, again, if you have B surface antigen positive active infection, you need to be on antiviral therapy to receive any of our therapies. If you have evidence of resolved infection with a hepatitis B core antibody positivity, they recommend that you follow the viral load and then treat as you wish. If you're not on antiviral therapy, you may want to be on a DMARD rather than a TNF inhibitor. Hepatitis C, if you're on treatment, you don't need to make any changes. You can do whatever you want. But if you're not on treatment, they recommend a DMARD, not a TNF inhibitor. This is surprising because John Revelle, who treats a lot of HIV patients down at the University of Houston, recommends TNF inhibitors, and for which he's had no problem. Skin cancer and melanoma, they recommend a DMARD. This is a big problem because most of our patients who have a history of skin cancer and melanoma are not on DMARDs alone. They're on biologics. So this flies in the face of current practice. If you had a history of lymphoma, they recommend rituximab. Surprising because rituximab is approved for CD20 positive B-cell lymphomas, but not for really any other condition other than RA. But if you have RA and you have a lymphoma, they want you to use this. However, the rituximab has not been studied in that setting, meaning patients with RA who develop a lymphoma or a lymphoproliferative disease that rituximab is the right drug to use. What has been studied at great length is thousands and thousands of patients who have received TNF inhibitors. Again, that would be my recommendation. Serious infectious events, they recommend combination DMARDs or abatacept over a TNF inhibitor. So there's a lot here to digest, a lot here to argue about, a lot will ensue about the appropriateness of these new guidelines. See you at the ACR. Tune in to Room Now.